kind of a, it's not one event, it's a group of events. Okay, it's a group of events that occur in a young girl at the age of, it starts around 9, around age of 9, and it, she gets various features like starting from growth spurt, breast development, and finally it culminates in a, in the first menstrual period. This, all these things called together as puberty. Okay, so we know the reason that in the hypothalamus, pulsatile secretion of the gonadotrophin releasing hormone GnRH from the hypothalamus uh, is the initiator. So initially it secretes in pulsatile fashion. Okay, pulsatile, frequently pulsatile fashion, pulsatile secretions of GnRH analogs will have will affect the, will influence the pituitary glands. From the pituitary, FSHL and LH will secrete, and these things in return will help to produce or estrogen, progesterone from the ovaries. Those things will act together and they will help to develop secondary female characteristics, secondary sexual characteristics, such as breast development and something called adrenache, that is because of the adrenaline secretion of adrenaline from the adrenal cortex, epiandrostenedione DHEA, which initiates the development of the sexual hair. All these things will help the woman to help the girl to develop the features of puberty. Okay, initially breast development and in line with acceleration of the growth, and after 2 years menarche occurs. Okay, so pubertal age will be depend on various things like, you know, factors, population, body weight and nutrition. And in Sri Lanka the age is around 13 years. All these things have been discussed with you somewhere else. Okay, in you know, there is a little bit of overlapping. Okay, so we normally, you should know when you take a history, when a girl comes with a history of uh, pubertal related issues such as commonly amenorrhea, so primary amenorrhea, or if the woman has not got a period, we should know to take a history properly. So these things matter a lot. Tanner staging, puberty, Tanner stage of puberty, we stage from stage 1 to 5. Okay, so this thing you should know from my slides. Then now you should know the basic characteristics. Prepubertal. Give me a second. Hello. Oh yeah, yeah. Okay. CTG, please. CTG, CTG. I need a CTG. Stop. Syntocinon and start a CTG, please. Okay, send it to me. Stop the syntocinon. Yeah, yeah. I want CTG. Oh, come on, come on. Stop syntocinon. Okay, okay, okay. Okay, so troubling people. Okay, sorry. So Tanner staging system, so you should be familiar. Now this is easy to know. Stage 1, no pubic hair, no breast development, and you know, and stage 2, minimal pubic hair and breast buds will develop. Stage 3, you have to have the picture and, you know, familiar. Normally you don't have to by heart this, but good to know. So what you have to do is you have to have the chart. When you get a patient, you cross check. Okay, this is the what stage she belongs to. So even in the exams you should be able to roughly tell what stage she belongs to. Okay, okay, this is stage 1 to stage 5. Okay, all this process, okay, from growth spurt that occurs, and breast development occurs, and tilake, adrenalake, what is, you know, we called it hair growth, and development of secondary sexual characteristics, finally periods. All this process needs few things: normal female chromosomal pattern, there should be functional hypothalamo-pituitary ovarian axis, responsive endometrium should be there to produce periods, anatomical patency, sometimes there can be obstruction in the female genital tract, and active support from the other endocrine organs such as thyroids and adrenals. Okay, all these kind of characteristics of these things should be there intact in order to complete the process. Okay, so primary amenorrhea is something that is defined as a failure to start menstruation by the age of 16. If the girl has developed good secondary sexual characteristics, then we call it okay. If the girl has by the age of 16, if the girl has not got periods, that means she is having uh, primary amenorrhea. But if the girl has no any secondary characteristics at all by the age of 14, then you can define her as a girl with primary amenorrhea. With secondary characteristics, we can wait up to 16 years of age. Without secondary sexual characteristics, we should wait. We can even start to work up or start to do diagnostic workups by the age of 14 if the girl has no secondary characteristics at all. Hope you understand this point. Okay, so there are features, there are the reasons are interruption of the onset and the continuation could be due to, as I said before, chromosomal problem in the hypothalamo pituitary ovarian axis, and defect in the anatomy, poor response in the endometrium, defect in the endocrine system. Okay, sometimes it can be constitutional. A lot of girls, parents bring the girls to us, and most of them are constitutional. Okay, hypothalamus, causes of primary amenorrhea from the hypothalamus to constitutional. Causes can be weight loss, intensive exercise, and pituitary issues, hypoprolactinemia, sometimes hypopituitarism, tumors, cranial irradiation in the past, head injuries. Ovarian causes can be gonadal degenesis and outflow tract problems. Mullerian agenesis, there is something called Mullerian agenesis, which I am going to talk to you now. Imperforate hymen, transverse septum in the vagina, sometimes chromosomal problems like Turner's and androgen insensitivity syndrome. Systemic disorders, chronic illnesses, weight loss, all these can be the causes. So you should ask from the history when a girl is where comes to you, you should check whether it is a hypothalamus problem. So in that case, severe weight loss, anorexia nervosa, intensive exercise, when the body mass is very less, very lean body mass, then they are at risk of getting hypothalamus related primary amenorrhea. Sometimes idiopathic, it can be idiopathic also. Hypothalamus problem, idiopathic hypothalamine disorder. Pituitary, hypoprolactinemia, hypopituitarism can be a cause. And again, damages due to tumors, previous irradiation, head injury, ovarian problems, gonadal dysgenesis. There is something called Swire's disease, which I'm going to talk to you again. There is something called primary ovarian failure. Ovary initially functions genetically, everything is okay, but they become their ovary fails to act or function ceases. Obstructions, so they have everything, genetic components are okay, uterus is okay, they menstruate, and the menstrual fluid blood can't come out because of the thick imperforate hymen or transverse septum in the vagina. Sometimes chromosomal issues, Turner syndrome, androgen insensitivity syndrome, all this can be again causes. Okay, all these things should be evaluated. This is a sensitive matter in the clinic. You have to talk to them nicely. You will be getting cases sometimes in the OSCE, MCQs common. We will put a lot of MCQs, and even the vibe in the history is also history very unlikely though, because it's a sensitive case, so we won't give cases as such. Okay, but you will get lots of MCQs, SBAs, and structural essay questions also. Commonly, congenital defects, genetics and developmental problems accounts for 60%. Endocrine causes can be nearly 40%. Okay, give me a second. So, multidisciplinary team approach is important. We normally, when we come to us, we do an ultrasound scan. We may need a pediatric endocrinologist, counselors, and detailed history is very important. You often take the history of the other children in the family and milestone development to see whether there are any congenital problems, paternity, like it can be consanguinities, sometimes it can be Downs, all these things from the birth history, the damage to cranium, damage to irradiation, chemotherapies, and exercise, dietary food habits, all these things should be taken in a detailed history. Sometimes it can be idiopathic, sometimes it can be hypothalamic causes, pituitary causes, uterine causes. All this should be taken into account. You have to have a checklist, make a balandona history, detailed history, weight loss gana handone, stressful events, life events, maybe it can be sometimes anorexia like related issues, previous stress, all these things matter. Okay. Any developmental delays, especially breast and axillary pubic hair, should be taken into account. And some in cases like if the uterine, if there is a menstrual blood, if sometimes transverse septum, there can be cyclical abdominal pain, and that can get collected and severe abdominal pain. They can come with acute abdomen sometimes. Okay. And also about galactria, visual disturbance if it is a pituitary problems. Okay. And signs of hyperandrogenism, all this should be taken into account. Major history, systemic illnesses, drug history, especially antipsychotics, family history. Okay. Premature ovarian failures in the sisters and other family members should be taken. Okay. General examination, again, as I said, you have to do a head to toe examination. Weight, height, body mass index, skin color, sometimes acanthosis nigricans can be there, eyes, visual ophthalmic assessment, thyroid status, dysmorphic features, hyperandrogenism features, axillary hair, tanner staging, galactria. All these should be taken into account in the examination. Okay. And also genital area, sometimes clitoromegaly, and labia. If the labia is there, sometimes you may have to, if there is no vaginal orifice, sometimes testicles, or the testicles can be in the labia or in the inguinal part, because it can be a male person because of the androgen insensitive syndrome. They are genetically males, but they are being grown or presented as a phenotypically female. So I'll explain it to you. You have to examine the labia also to see whether there are testicular masses. Okay. We'll think now. We'll quickly go through cause by causes. Can uterine causes lead to primary amenorrhea? Yes. If there is something called Mullerian agenesis, very rare, you have to go back to your embryological this thing. So there can be, uterus won't develop, hypoplastic or sometimes absent uterus, and only vagina, small piece of vagina, or vagina is also blind-ended vagina. So this is due to genetic mutation, not a chromosomal disease, genetic mutation. Okay, during embryogenesis, normally they produce ovaries, ovaries produce estrogen hormones, and only thing is structurally hypoplastic, aplastic uterus. Rest of the things are normal. So you need to do either an ultrasound or MRI to diagnose this when you have clinical suspicion. Okay, breast development will be fine. But there are a lot of varieties in these variations. Okay, they also can have isolated renal, vertebral, and auditory problems associated with this. These are MCQs. Okay, isolated, it can be isolated or associated with renal and vertebral problems. This is called, again, the classical one is called Mayer-Rokitansky-Kuster-Hose syndrome. Again, you will get a lot of MCQs. Okay, Mullerian agenesis, typical one is called, 4 people have involved in the diagnosis or the kind of introduction, or they only found it, or they suggested, they brought it up. Okay, so major Rokitansky-Kuster-Hose syndrome. So this is the picture. You can see the small remnant or Mullerian remnants, ovaries are there, there is a big gap, and only dimple vagina. So this is type 1. Okay, here in this case you can see the normal one as well as undeveloped organs in the May-Rokitansky-Kuster-Husser syndrome. Ovaries, tubes will be fine. Uterus will not develop. Vagina will be a kind of blind-ended vagina. Okay. So when they come, so they come with primary amenorrhea mostly. Okay. And normal secondary characteristics. So when you examine, vagina will be blind-ended. So the hormone profile will be okay. Karyotyping will be normal. Only thing is structurally, when you examine, vaginal dimple will be there, and when you do a scan will show okay, no uterus, no structural, structurally no uterus. We confirm it with MRI. Some people go into, if the MRI facilities are not there, some people even do a laparoscopy to see whether uterus is there or not. Okay. So some people, some variation, small functional uterus will be there, and they time to time they bleed and cause symptoms time to time that can get collected. Those are called horns, removal of the horns. Uterus blindly, small horn can be there, and that is not connected with the vagina. So when the age of menarche comes, they get the blood collected inside and cause problems. Okay. So so they are very commonly, they come with subfertility. Some people come to the fertility clinic and it's very difficult to tell them, okay, you have not developed vagina, and they can't have children on their own, basically in their uterus, because there is no uterus. So you will have to go for surrogacy. Surrogacy means you can hire someone else's uterus. They will produce eggs, and we have to do stimulation and grow the eggs inside them, and we pick up those eggs and make the embryo and implant in the other's uterus. So that is called surrogacy. Okay. So diagnosis, again, you do hormone profile, that will be normal. Karyotyping will be normal, and we do ultrasound to see whether the uterus is there or not. Okay. So in addition to that, we have to do x-rays, audiogram, 2D echo, IVU, because they can have some other problems like vertebral issues, auditory problems, heart defects can be there. Okay. So counseling, a lot of psychological support, and mainstay of management is surgically restoration. Fertility, as I said, surrogacy is the main management plan. Mainstay of management is surgically. There are lots of techniques. Creation of neovagina. We pass a small, the surgically we dissect into the vaginal tissue, and we make a hole. And there are various techniques. You don't need to know all these techniques. Just read. Interesting. When you go to online clips, online, or if you Google, you will find lots of surgical techniques in the YouTube. Commonly, we do suggest non-surgical management. There are things called cones. We ask them to insert it and just make the way slightly deeper. So we don't normally do in the children. We tell them at the age of marriage only we can advise us, because to keep it intact, we don't do surgical procedures when they are kids. Okay. There are procedures called McIndoe procedure. That is very common. Just Google and see. You don't need to do surgical procedure, name of the surgical procedures, but surgical creation of neovagina is the thing that you need to know. Sigmoid Vaginosplasty. Surgically, what we do is, since there is no vaginal orifice, we pull the sigmoid colon and make a small diverticulum like thing and connect it to the vagina. So sigmoid colon, a piece of sigmoid colon can be used as a vagina. So the problem is that can cause secretions, but that has been done. Even in our hospital, we do it. Okay. And there is something called Williams vulvoplasty, vaginoplasty, Vichetti procedure. All these are there. You don't know the names, but creation of neovagina is the name that you need to know. We keep a mold. We create a small regiform mold and surround. As I said, I told you in the previous lecture also, we surround it with the amnion of the placenta and keep it in the vagina. The amnion will be taken up the vaginal tissue, and that will become epithelialized, and the patient will be able to have sexual intercourse. Okay. Fertility, egg retrieval, and IVF and surrogacy is the management of choice. Androgen insensitive syndrome, that is again another issue that we come across. They are genetically males. Okay. They have XY genes, and the XY genes, but androgen receptors are not functioning. So there is a defect in the androgen receptors. So these people develop, they can't. So because of that, cell they don't respond to androgens. So genetically males, okay. So what will happen is they will the female part will grow, okay. They will have a testicle also, but lot of estrogen, androgen, excess androgen will become estrogenized, and because of the estrogen they develop breasts, and they grow like females. But actually they can have testicles, and they have kind of, it's a slight small labia, but no penis, clitoris will be there, okay. Because this is because androgen can't act to form male secondary sexual parts because of the insensitivity in the androgen receptors. So these androgens will be converted to estrogen, and those people develop breast and they will grow like females. So androgen insensitivity syndrome. So the thing is, so Mullerian normally testicular inhibitory factor. So there is something called normal secretion of testicular Mullerian inhibitory factor. The uterus will regress, okay. So uterus, there won't be any regression of there will be a regression in the uterus. So male, they are genetically male, okay. So what will happen is, normally when you feel, there are variety of cases, variety spectrum of diseases. They can be partial or complete, okay. But some of them will be having little bit of virilization, that means male like features also. Some of them will appear completely like females, okay. So they will require, sometimes the clitoral require, they want to behave like females, most of them. So reconstructive surgery and clitoral, they will have a penis, so they will reduce it to the clitoral size, and they want to have a vaginal orifice, and all this can be constructed surgically. And some of them would need hormones also, hormones to female, to maintain as a female, they require hormones. So, and also most importantly, when they have gonads, that can become cancerous. So after puberty, we surgically remove, okay. So they normally we do it to psychiatrists. Psychiatrists will assess them, and they will counsel them, and they will identify the sex, and they will talk to them, and then we remove the testicles. It's a complex thing. Just read about it. I don't think I will be able to cover it in one go in this lecture. Hypothalamic causes, again, amenorrhea of hypothalamic origin is due to either exercise, eating disorder, nutritional deficiencies. As I said, GnRH will be reduced because of impaired pulsatile release, can lead to the problems in the cascade of the events, okay. So low circulating hormones, this is called hypogonadotrophic hypogonadism. Hypogonadism. So the range of all the hormones, from the GnRH, FSH, estrogen, progesterone, everything will be low, okay. So because of the lack of the GnRH hormones, okay. මේ කට්ටියට කියන්නේ hypogonadotrophic hypogonadism කියලා. And you usually need multidisciplinary approach. Endocrinologist will get involved, and we can make them conceive if we give pulsatile GnRH analog. I told you in the previous lecture, okay. You have to assess the rest of the things, whether it can be a functional case, it can be a stressful life events, it can be idiopathic, it can be a cancer. There is something called Kallman's disease. Kallman's disease is idiopathic hypogonadotrophic hypogonadism, and these people have usually absence of smell, anosmia, and grossly reduced sense of smell. Make a COVID killer diagnose කරන්න එපා. So it's a, again, this is a common MCQ. I was joking. This is a common MCQ. Kallman's syndrome ගැන අහනවා. Hypogonadotrophic hypogonadism. Okay, we give HRT fertility treatment can be, since they can have other problems, including cleft lip palate, midline craniofacial defects, renal agenesis. All these things should be investigated. Multidisciplinary approach is important. We give HRT, we give fertility treatment, and they can conceive and have a child. Pituitary causes, as I said, prolactinoma can lead to problems, and prolactinoma, lot of causes you have to read about it. Any prolactin secreting tumor can lead to this problem. Okay, there is something called the empty cellar syndrome, that is again prolactin dysfunction. Read about it. It's a cause of pituitary cause of primary amenorrhea. Sheehan's disease. Sheehan's disease is something after that occurs after delivery. If they deliver, severe postpartum hemorrhage can affect posterior aspect of the pituitary, leading to all the heme or hormone system to go off. That can lead to, that is called Sheehan's disease. Okay, they usually, that is not the primary, that is not the cause of primary amenorrhea. That is a cause of secondary amenorrhea. Okay, so prolactinomas managed with medically, surgically, and radiotherapy. You have, somewhere we have discussed this. I'm just, going through it. And outflow obstruction, outflow tract obstructions are common. Imperforate hymen. They present to the gynecology ward with severe abdominal pain, cyclical abdominal pain, and abdominal pain. So when we examine, we feel bulging septum in the hymen. So we take them to, it is called hematocolpos. The collection is called hematocolpos. So you see transverse vaginal septum. We surgically, we make sometimes multiple septums can be there. So we'll have to take her to theater and we cut it, and we let the old blood drain, and we may then that will we make a small incision. So that is enough for them to menstruate. Okay, so here you see a picture of hematocolpos. So hematocolpos කියන්නේ vaginally collected blood, that menstrual blood get collected and that can't drain because of the septum. A name area of ovarian origin. There is something called Swire Syndrome. These are primarily dysgenesis in the ovaries. So either Turner syndrome is a condition, chromosomal X node condition, and ovaries bone dysfunction. All the primordial follicles will become atrophic, and they go into primary amenorrhea. Sometimes premature ovarian failure. That they also even premature, that can lead to primary amenorrhea or secondary amenorrhea also. Sometimes young girls, small girls can become polycystic obese, and they develop polycystic ovarian syndrome and they don't menstruate. So that also can lead to primary amenorrhea. Okay, so all these are causes. These are the features of Turner syndrome. I'm not going to discuss this. So when they come, they have all the features, and when you do a scan, streaky ovaries or small ovaries will be there, and when you do FSH-LH level, that will be very high. So this indicates that they have less, FSH-LH will be high because pituitary hormones will don't have negative feedback from the ovaries. Ovaries don't produce estrogen, and FSH will be high in cases of Turner syndrome. And when you do a karyotyping will show X node karyotyping pattern. Okay, so for them we start HRT, and with the help of endocrinologist. So I'm going to skip this. It's a very rare disorder. Just read about it. Swire disease, and it's again a mutation in the SRY gene. Actually, they are males. They have Y chromosome, but X sex determining region is gone. So this leads to absence of anti-Mullerian hormone and testosterone. So the normal uterus, fallopian tubes, and female external will develop, but gonads will be very streaky. Okay, they will have a streaky gonads. Okay, Swire syndrome, very interesting. Just go through. You will get some pictures, historical events, and all these things. You can just read and understand. Swire syndrome. It is because of the problem in the SRY component in the Y chromosome. They are genetically, they are supposed to be males. And we have to do gonadectomy and HRT, and ovum donation and IVF is possible because they have uterus and tubes. Constitutional delay is the commonest because it can be familial and idiopathic. So first we have to exclude all the other causes, genetic, chromosomal, hypothalamus, pituitary, hormonal, structural. All this should be excluded by by taking history and investigation, and then only we diagnose constitutional delay. This is a line of investigation. Just use this as a I have summarized, or this is the chart. This chart explains how you should systematically work up when a girl comes with primary amenorrhea. Secondary amenorrhea, again, absence of menstrual period after 6 months. Common causes, it can be pregnancy, polycystic ovarian syndrome, we have talked about it, androgen secreting tumors, ovarian causes, premature ovarian failure, pituitary, all this. The other rest of the other causes also can become secondary, can become a cause of secondary amenorrhea. Okay, so physiological conditions, breastfeeding, pregnancy, exogenous hormones, and all this. So this chart, again, it lists all the causes. Just go through one by one, and you can tally it with the principal slide that I put. Just go through the causes, and whenever you have a case, just evaluate based on this the previous workup plan, and go through this slide. This is a big list you should know. Okay, premature ovarian failure. So I'm going to quickly check with Asanka to see whether. Okay, premature ovarian failure is, again, menopause occurs at before the age of 40. If they don't have විනාඩි දෙකක් දෙන්න පුළුවන්ද ඔයාලට කොහමද? මොකද දෙන්න මම ඉවර කරන්න right? Okay, premature ovarian failure is again, you will get a lot of cases. They present with hot flashes, they would have had normal children, they come with a history of amenorrhea for 6 months or 4 months in a kotama. You may have to, ideally 6 months, but diagnosis is widely, we investigate if they, without any causes, if they come with the history of period of amenorrhea for 4 months, we should do a follicular stimulating hormone. And if that level is more than 30, we diagnose, okay, ovarian failure, but we need at least 2 tests 1 month apart. Okay, so even one would be enough for us to tell, but we normally check because there can be changes, ovarian functions can change. Okay, so menopausal symptoms, you should know, hot flashes, all this list of things can occur. So you may have to quickly investigate and start HRT. Again, premature ovarian failure, you need to know certain things. It can be idiopathic, it can be autoimmune disease, it can be due to some other medical disorders, or previous, as I said, radiation, chemotherapy, all this, TB. So there is a big list. Okay, so premature ovarian failure. Wait, here I think no, there is no list. Okay, so just premature ovarian failure, you won't be questioned as such, but you should know these are the basic things. Okay, it is similar to what I said before. It can't be a structural cause. It is an ovarian failure. Functioning ovary has failed. It's either problem in the HPO axis or hormonal imbalance or disease condition. So you should take a detailed history. So PCOS, I'm not going to go through because we have talked about it. Any questions? So this is an important slide. Okay, this is a workup slide. Okay, so how we go through this. So if you read this only, you will understand. We will be giving you lots of questions, MCQs, OSCEs. So those are very simple questions, but for you to you will have to think. Okay, it's you have to make a workup plan. It's a very beautiful workup plan. Just go through it once or twice and then make us make a note. Any questions?
So I have one question.
Yeah, tell.
You said that in the transvaginal septum that blood collects in the proximal uterus.
Yeah.
So in the condition, I can't remember the name. In the Mullerian agencies, is it similar?
No,
Is there a
Mullerian
difference?
agenesis is completely different. Mullerian agenesis is uterus won't be there, but in some patients, there are variety of Mullerian agenesis. Sometimes mal-developed uterus, which is small endometrium. That is not similar to this. They will have a cyclical pain and abdominal distension. When we do a scan, uterus will be there, small collection inside will be there. In that case, we have to do a surgical excision. We have to do a laparoscopy, cut into that area and take it. Here, you rest of the structures are okay. Only in the down part, there will be a kind of block or kind of an obstruction. That is just, that needs only a drainage. We get it to casualty ward. Rest of the structures are okay. If you put a small cut here, she will drain all the blood. Okay. Any questions? Okay, I'm going to leave it to Asanka then. Bye.